Hi, welcome to Detours, Understanding Acquired Brain Injury. And today I want to tell you a story. I want to tell you a story about a man who was a railroad foreman in the 1840s. Those of you who took psychology may recognize this story. This railroad foreman was industrious, hardworking, and he led a large gang of railroad workers. Now, a railroad foreman, was an expert with explosives, black powder, which was what was available at the time. Stories like his eventually led Alfred Nobel to invent dynamite, but let's move on from that. He would use the black powder to blast into the sides of mountains and to move rocks and things like that. One day, he was working with the black powder and using a tamping rod, which is used to drive down the black powder into holes, cracks, crevices, things like that. And there was a spark, and it blasted the tamping rod up and through the left side of his head, through his brain, and up and out his skull. It devastated his left frontal lobe. It destroyed the ventromedial and much of the dorsolateral aspect of his frontal lobe, which means it would have gone through here, up, and passed through this area of his brain inside and went through his skull. Now, what amazed the physicians who were called to examine him, first they were amazed he had survived such an incident, and the fact that he could walk, talk, move, that he seemed to be all right. Now, he's a tough, strong guy, but they were just astonished that it didn't seem to have affected him. And then they figured such a devastating injury should have, if not killed him, permanently disabled him. But soon it became clear that it had indeed affected him, but not in the way that they had initially expected, because this was an age when neuroscience really was only beginning to develop. Those of you who know and have seen me talk about speech and language. He had changed radically as to who he used to be. He had become quarrelsome and angry very easily. He had problems with social interactions. He would be willing to pick a fight with anybody. He would swear very openly and willingly. And this was not a man who swore. He's a church-going man. He believed, and he had problems with thinking and organizing. And he was a railroad foreman, and you had to be well organized. You had to be able to put your teams together to plan how to lay down the tracks. He couldn't do it anymore. He had, with his serious frontal lobe injuries, lost the ability to perform both his social skills that were so necessary, as well as lost executive function. And this is how a lot of neuroscientists who came later came to understand, through the serious injuries that happen to people who suffer brain injury. These are called lesion studies. And this man I'm referring to is called Phineas Gage. And his story is famous in the annals of neuropsychology, study of how brain and injuries and studies of the brain apply to behavior and thinking. And so this is a story of Phineas Gage. And what happened to him, it's unclear. Some stories say he ended up just homeless, kind of wandering around the country. Others say he eventually overcame some of his problems and ended up as a successful coach driver and, working with a group of coach drivers. Don't know. His history, disappears in the mists of time, as often happens to a lot of these kind of case studies. But what I want to talk to you today with Detours is about personality and brain injury. So what we're going to do is we're going to talk about first, what is personality? Changes to personality often are what really it is that causes the most difficulty when somebody suffers a brain injury. And it's often what leads to divorces or leads to families stop communicating or have problems with a loved one who suffers traumatic brain injury. So let's get into it. First, personality is a series of characteristics, traits, which are persistent over time. That is, things you expect a person to do behaviorally and emotionally. And behavioral is important because these are characteristics or ways of interacting that are measurable, documentable. And I've talked about this before, frontal lobe injury, that behavior is something you can measure consistently. Okay, now that's what personality is. So it is a consistent set of behaviors and traits which are measurable over time, or which are observable and which are consistent over time. All right, so with traumatic brain injury, and any kind of brain injury, let's look at how it's characterized by the DSM-5-TR. Okay, the DSM-5-TR, this is the book used by American clinicians, and the definition for personality problems with personality are similar. For the ICD-10 and 11, they're pretty similar, but this is how it is defined. Personality change, which would go along with major cognitive, neurocognitive disorder or minor neurocognitive disorder. See the other video here. This would go along with it, and it is personality change due to another medical condition. So if somebody changes their personality due to a brain injury, you would also give them this diagnosis: personality change due to another medical condition. And this applies to other forms of acquired brain injury. So first, persistent personality disturbance that represents a change from the individual's previous characteristic personality pattern. First, so it has to be persistent. This has to be a new set of characteristics that were not present before. Okay. Second, there's evidence from history, physical examination, or laboratory findings, so imaging, things like that, that the disturbance is due to the direct pathological circumstance from this medical condition. So it has to be related to what happened to them. Third, the disturbance is not better explained by another mental disorder. So these changes cannot be due to depression or anxiety or some other mental health problem, or due to a pre-existing personality disorder. So it can't be from, say, if before their injury they were diagnosed as borderline or narcissistic or whatever. So you cannot apply this diagnosis if they were already diagnosed with this mental health disorder. Now, it doesn't mean they can't have had it, but the personality changes that you're seeing to receive this kind of a diagnosis cannot be the reason for them having a personality change. In other words, it has to be due to the brain injury. Okay? It has to be due to the brain injury if you're giving them this diagnosis. The disturbance does not occur exclusively during the course of delirium. So it can't be a brief period where they're still waking up coming out of a coma or something like that, or coming out of anesthesia, or where they're coming out of medication-induced. This has to be persistent changes. Finally, the disturbance causes clinically significant distress or impairment in its social, occupation, or other areas of functioning. Remember that from the major and minor cognitive disorders? Same thing here. It has to cause trouble with social or with occupational or other major areas of functioning in order for this to be applied. And then you specify what changes are present. Labile, which the predominant feature is affective lability. So quick changes in mood, happy, sad, angry, depressed, like quickly going from happy to sad to angry to quickly changing moods. So this is one of the specifiers. So you can say personality change of the labile type. I have that to a degree. It's due to my injuries. Disinhibited type. The predominant feature is poor impulse control, as evidenced by, for example, sexual indiscretions. This is another change that can be manifested due to personality change. Aggressive type. This is very common. Predominant type is aggressive behavior. Now keep in mind, this is behavior, not feelings, but if they act out, if they're quick to fight. Okay? Apathetic type. If the primary predominant feature is marked by apathy and indifference, they don't care about anything. So you would characterize them, and remember, this is a change. This is not old behavior, this is new behavior. Now, suddenly, after their brain injury, they don't care about anything. New behavior. Paranoid type. If the predominant feature is suspiciousness or paranoid ideation, if they're afraid of everybody, the government's out to get me, you're out to get me, everyone's plotting against me, and you give them the paranoid ideation. Other. If it's any or many of the different subtypes that we just discussed. Combined, if you put together 2 or 3, they're paranoid, but at the same time they're labile, their moods quickly change, then you would give them other. Or you'd give them combined. I'm sorry. And unspecified covers anything they couldn't think of. And so that is how you would apply this. And so there are associated things that you would apply along with them. For example, a variety of neurological and other medical conditions may cause these changes. For example, we know head trauma is one of them, but also cerebrovascular disease, stroke, aneurysm, things like this may cause these kind of change. Sepsis, we talked about that, may cause a personality change. Infections like this, epilepsy, chronic seizures can cause brain changes like this. Changes in different hormone levels in the brain may cause this. But it has to be enduring. That is important to remember. It's got to persist. Hypothyroidism, hyperthyroidism, persistent though. Tumors, brain tumors can do this also. Of course, any sudden personality change that you cannot find the cause for requires physician intervention, requires imaging. You need to know what's going on. You need to look at laboratory testing, assessment, any of that kind of thing. There are all different kinds of personality changes. With the most extreme kind of disorders in personality, you can get a very severe regressive type. In certain types of personality problems, especially after traumatic brain injury, you can get a regression to the point that they're almost childlike. It's rare to see this, but almost total destruction of the frontal lobes can lead to somebody becoming almost like a kid, like a 3 or 5 year old almost. Again, not common, but it does occasionally happen. They'll behave very much like they're 3 to 5. Those cases are very dramatic. They're difficult to treat. You may also get pseudo-psychopathy. A person seems almost like a psychopath. I talk about this. I have another video. Damage to white matter tracts. They become callous and unfeeling. Some degree of meanness, aggressive, but at the same time, they really don't have the ability to plan or organize anything. They're not like some criminal mastermind or something like that. They just don't care if they hurt you, and they're not going to apologize. They're not going to feel badly for it. And then there are other kind of ones that we just mentioned, where a person with brain injury may have like specific elements, like I'd said about either apathy or maybe aggressive, quick to fight, or those other things which tend to be more common, where you just get specific symptomatic changes. How do you treat it? Well, a lot of these, usually it's behavioral interventions that help. Things like positive reinforcement for acting appropriately, withdrawal of attention, and leaving the space. It's risky sometimes to do that, but if you reinforce bad behavior, if you reinforce inappropriate behavior, you end up making it worse. And people with brain injury are very sensitive to this kind of reinforcement, so you need to be smart about it. They tend to react better to positive reinforcement, so be quick to reinforce appropriate behaviors. I like that. I like what I'm seeing. And then there's the role for medication. Beta blockers are a good choice to help with settling down. In desperate cases, neuroleptics, antipsychotics, the older ones, are more effective. We want to avoid benzodiazepines, not good for brain injured people. And finally, it is a structured environment. Chaotic environment is not good. You want an environment where things are predictable. Who they come in contact with is known. This is especially better for people with the most severe brain injuries. People who are higher functioning, you can rely on them to use their reasoning. And they can see and understand. So explanations work better. but you still would need to use some of these early on, some of the behavioristic and the some of the medications like earlier on when they're relearning. But as their functioning improves, you can rely more on explaining things. In a lot of ways, it's things you would use for younger kids and things you would use when you're dealing with like people with autism or people with severe learning disorders and things. And some personality disorders are due to problems with cognition. In fact, many of them have problems with cognition because they don't understand. And so explaining, no trying to be dramatic or anything with it, just lay it out. That is also a way to help people with personality disorders. Now, if they don't understand, can't understand it, if they're having serious processing problems, then you have to rely on the more behavioristic, more reinforcement punishing, or just withdrawing attention. Sometimes some just... And finally, time. Many of these things do actually improve with time. As the story reflecting back to Phineas Gage, I do believe he did get better over time, but like I said, he kind of faded in the mist of history. And other people that we've seen with frontal lobe injury, there are improvements over time. So these are some of the things. Now, there is research, new medication, stem cell therapy, which may reduce inflammation, and hopefully at some point we'll literally be able to grow new cells for the frontal lobe and to improve those kind of connections and things like that. And perhaps some research is going into direct brain stimulation, not external magnetic stimulation, but I'm talking about direct implants in the brain to stimulate those areas and help reconnect things that have been broken. But all this is university research and stuff like that. It has not hit use by the neurologist and neurosurgeon yet. So these are some of the things. We all know I've talked about the frontal lobe, things like that a lot, and I've talked about the kind of areas that are involved. I talked about the ventromedial area here, which is big time involved when there is a disruption, especially the more impulsive and more like the loss of empathy and like those kind of problems, as well as problems with theory of mind, the understanding of how other people think and how you feel. Those kind of problems definitely play a role in relating socially to others. The dorsolateral aspect of the frontal lobe, thinking about like planning or understanding other people's thoughts, things like that, and like that kind of intuitive or gut feeling, same kind of thing. And so all of these things are what contribute to these changes in personality that so many people say, oh, he's not the guy I married, she's not the girl I fell in love with, that kind of stuff. These are why these kind of changes to these areas of the brain, and these are like where a lot of this comes from, and these are how we make the diagnosis and some of the possible treatments, as well as some of the potential future treatments. Unfortunately, these are the things that lead to the most trouble in employment and lead to a large number of brain injured people being imprisoned. So I think it's important for us to talk about this topic. And I'm coming to the end of discussing the frontal lobe now. I mean, I'll probably revisit it later, maybe with more research and other things and medications, but I've kind of covered the frontal lobe extensively. And so now I want to switch over to talking about things like the temporal lobe and the parietal and the occipital lobe. But I wanted to get this in here too. So hope you enjoyed it, hope you found it instructional, and hope it helped explain some things about personality and brain injury. Have a good day. And please like and subscribe, hit that bell icon to get more like this. And thank you very much. Please share these videos with people who may benefit. Have a good day.